Hi, this is Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on this week's video. On this week's video, I want to share with you part 3 of our 4-part series on QME report writing mastery. And today we're going to focus on the proper formatting of the physical exam. And I'll talk a little bit more about that here in just a couple minutes. But before we do that, I just want to recap and review some of the key ideas that we discussed in parts 1 and part 2 of this series. And remember that the overriding theme of this program is to produce QME reports that are clearer, that are more credible, that are more persuasive, that are more powerful, and that present you in the reader's eye as a competent and qualified medical evaluator, a qualified medical evaluator. And I have dozens and dozens of ideas that I'm sharing with you, which if you simply implement 2, 3, 4, or 5 of these ideas into your reports, it will immediately and irreversibly improve the content and quality of your reports and will significantly enhance your reputation as a competent and qualified medical evaluator. So let's just recap some of the key principles from part 1. In part 1, we talked about the necessity of creating a custom template specific for use in your qualified medical evaluations. And many doctors are using random text generating report writing software that they use in their clinical practice for the purpose of either taking SOAP notes or for producing reports regarding personal injury claims. And these report writing softwares that are available were never intended for use in California's workers' compensation and were never intended to be adapted to the AMA Guide's 5th edition. So if you're attempting to put a round peg in a square hole and you're trying to use this random text generating report writing software from your clinical practice for your QME exams, I want to be honest with you and simply tell you straight out that it's not working. It does not work. And let me also tell you this, the reader of your report knows that your report was created with report writing software because it sticks out like a sore thumb. And something tells me that you probably already know this, but you simply haven't taken the time to create a custom and specific template for use with qualified medical evaluations. Now, I want you to know that if this describes you, meaning that you do not have a template to use, I have a template available for you. I have the very best template that you can find in the entire industry. And I highly recommend our QME report template. It's been improved hundreds and hundreds and hundreds of times. It's been used by hundreds and hundreds of evaluators successfully up and down the entire state of California, and it's survived thousands and thousands of QME reports. It's the very best template available, and it's very inexpensive, and you can use this template for your next 10 years of evaluations. All the hard work has already been done for you. So if you're using report writing software, I highly recommend that you either create your own specific template for use with qualified medical evaluations, or if it's more convenient for you, you can get our template. But create some sort of specific template for your QME exams. Okay? Then the next thing that we talked about was the necessity, the essential component of your report is clarity. It's important to be clear in your report. It's important to be clear when you render your opinions and conclusions. And so we talked about removing unclear words and unclear phrases from your report. We talked about removing language that softens your opinions and conclusions. We talked about the necessity of using short declarative sentences, sentences that are clear, sentences that are definite, sentences that are declarative. And we talked about removing softening language, language which detracts from the persuasive power of your opinions and conclusions. So, for example, some examples of softening words and phrases would be words such as apparently. Apparently. Apparently is a softening word that detracts from the statement that follows it. Phrases such as it seems to me. Words such as probably. These are softening phrases that detract from the conclusory power of something that would be more declarative. We also talked about removing phrases such as it is my strong opinion, or phrases such as in this examiner's opinion. In this examiner's opinion. In this examiner's opinion. See, this is a softening phrase. It's a softening phrase that detracts from the power of your conclusion by placing your conclusion in the mouth and at the pen of some third party other than yourself. It is this examiner's opinion is much softer and less powerful than simply stating, in my opinion, mine, it's my opinion. Be strong in your opinion. Do not soften your opinion and conclusion, and be clear with short declarative sentences. We talked about the way that the human brain stores and retrieves information through the use of folders. And we devoted the entirety of last week's program, the part 2 portion of this program, into identifying and naming the specific folders that we use in our QME reports. Folders such as the introduction folder, folders such as the demographic data folder, the history folder, the relevant medical history folder, the review of records folder, etc. And we went into that at great length in last week's video. Also in last week's part 2 discussion, we talked about the necessity of a couple of things. The necessity, number 1, of preparing the review of records yourself and not having any third-party service prepare the review of records for you. We talked about the necessity of preparing the complexity factors yourself and not having any third party involved with such delicate matters as establishing the billing level and support for the billing level of your report. This is something that absolutely must be done specifically and by no one else but you, the author of the report. We talked about the necessity to use impartial, objective, and unbiased language. The opposite of that is partial and biased language. And it's important that the reader of your report perceive you as impartial, as neutral, as objective, and as unbiased. Regardless of where your opinion and conclusion may fall on one side or the other, it's important that you be perceived as not invested in the outcome of the report or of the case, that you're simply a neutral, impartial, and objective and unbiased evaluator. And we portray to the reader of our report the presence or absence of our biases with our language. So we talked about the necessity to remove biased language from our report in favor of language that's more neutral, that simply reports the facts. Okay? And then finally, before we get into today's material, we finished up last week, part 2, by talking about how to incorporate into the body of your report some of the significant findings that you are able to glean from either the medical records, other documents, or possibly even symptom questionnaires. And I simply stated that it's not necessary to recapitulate the entirety of any document into the body of your own report. It's sufficient and satisfactory to simply summarize the key points, the salient points, and the points upon which you rely later on for your opinions and conclusions, those are the points that you want to include in the body of your own report. Now, some doctors find it necessary and desirable to recapitulate the entirety of documents into the body of their own report. And I'm sure you can imagine that if an examinee has had 50 or 100 patient encounters with various treating doctors and specialists and various diagnostic studies, that recapitulating the entirety of these documents can create a QME report that's unnecessarily lengthy. And this extraneous and superfluous review of medical records does not in any way enhance the content or enhance the quality or enhance the conclusions of the report. These lengthy and extraneous reviews simply gobble up page after page after page of report space and are simply obnoxious to the reader. So it's satisfactory and sufficient to simply summarize the key information from these documents. And there may be documents upon which you don't have any summary to report. If the information contained in that document does not in any way influence your opinion or conclusion, then that may be a document that you choose to simply bypass and not summarize at all. Okay? So this will contribute to reports that are more concise, more to the point, and allow the reader of your report to simply get the opinion, get the conclusion, and go on with the remainder of the day and the rest of their life. Okay? So that brings us now to part 3 of this program. And part 3 is devoted to the proper formatting of your physical exam. And we're going to use the lower extremity examination template to illustrate the general principle that I want to share with you in today's video. And let me just provide a couple of introductory remarks before we go to the lower extremity template. Now, it's important to understand, and it's important to realize, and it's important to recognize that the physical examination that we do in our qualified medical evaluation is different from the physical examination that we do in our clinical practice. In our clinical practice, when we do a physical examination, we do that examination for the purpose of establishing a diagnosis. Once we have established the diagnosis then drives the treatment program. So in our clinical practice, we do various physical examination maneuvers in an attempt to discover what's the diagnosis and therefore what can be done to help alleviate or relieve or improve the diagnosis. Well, it's interesting. In our QME practice, we're not rendering treatment of any kind. And so the physical examination that we do in our QME practice is not done for the purpose of establishing a treatment program or for the purpose of establishing a diagnosis. Rather, the physical examination that we do in our QME practice, we do that examination for the purpose of determining the presence of or the absence of permanent impairments. Let me say that again. In our QME practice, we do our physical examination to determine the presence or absence of permanent impairments. Permanent impairments and diagnoses are completely different things. And there's a subtle nuance in the difference between the physical exam that we do in our clinical practice compared to that which we do in our QME practice. And let me just illustrate this point. In our clinical practice, and I'm going to give you a spinal example because I'm a chiropractor, but the same principle applies to an upper extremity condition, probably would apply equally well to an internal condition as well. I'm simply using the spine as an example. In our clinical practice, when a patient comes in with lower back pain, we use a variety of physical examination maneuvers to help us identify what could be the cause of that pain, and then also to help us identify what is the appropriate treatment for this specific condition. So, for example, we use physical examination maneuvers such as Kemp's maneuver, such as Milgram's maneuver, such as Goldwaite maneuvers, such as Lewin's maneuver, such as Gainsland maneuver, and such as Ober's test. And all these physical examination maneuvers that are valuable to us in our clinical practice. Well, guess what? Nowhere in the AMA guides is there even one mention of Kemp's test, Milgram's test, Gainsland's test, Lewin's test. None of these tests are mentioned in the AMA guides. Why is that? Because Kemp's test does not reveal the presence of a permanent impairment of the spine. Typically, we think of Kemp's test as being pathognomonic for the presence of what we refer to as a facet syndrome of the lumbar spine. Well, guess what? Facet syndrome is not one of the permanent impairments described in Chapter 15 of the AMA guides. So skip Kemp's test. You can skip Milgram's test. You can skip all these tests because they have no relevance to the evaluation of permanent impairments. The physical examination that we do in our QME practice is different from the physical examination that we do in our QME practice. And I want to share with you what the AMA guides say about the physical exam today, using the lower extremity as an example to perfectly illustrate how to properly format your physical examination in a way that coincides with the requirements of the AMA guides. Okay? So let's now go to the lower extremity exam template, and we'll illustrate some of these principles. Okay, so here we are at the lower extremity examination template. Well, this is the QME report template. Let's go to the lower extremity exam. It begins on page 70. And here's the lower extremity examination template, okay? So anytime you have a lower extremity involvement in one of your injured workers, you're going to be doing a lower extremity exam. Now, this applies whether the involvement is at the ankle, if the involvement is at the knee, if the involvement is at the hip, if it's at the thigh, if it's at the calf. If your examinee has involvement of the lower extremity, we're going to start looking at the lower extremity more globally than regionally. So in the case of a lower extremity involvement, we need to be prepared to do a lower extremity exam. And the AMA guides describe several different types of impairments of the lower extremity, each of which needs to be examined for. In other words, we need to assess the examinee for the presence or absence of the impairments of the lower extremities. And this is a principle, and we refer to this principle as know the impairments, and examine specifically for the presence or absence of the impairments. And this is different than what we would do in our clinical practice. In our clinical practice, we examine for the determination of a diagnosis. So how does this relate to the lower extremity? Well, let's go over this now. So our lower extremity exam template is organized perfectly, as you'll see, according to Chapter 17 of the AMA guides. So let's just read this. It says, the physical examination of Mrs. Jones was completed according to Chapter 17 of the AMA guides. Page 525 of the guides, and I'll show you page 525 in just a minute. Page 525 of the guides describes 3 methods of assessment of lower extremity structures. We assess for anatomic impairments, we assess for functional impairments, and we assess for the presence or absence of diagnosis-based impairments. And let's just go to page 525 of the guides 523. Here's page 525 of the AMA guides, and they talk here about the different types of assessment for lower extremity impairments. We have anatomic assessments, functional assessments, and diagnosis-based assessments. So when you're thinking of evaluating your examinee for their lower extremity, you need to be prepared to assess for all of the anatomic impairments, such as limb length discrepancy. You need to assess them for muscle atrophy. You need to assess them for ankylosis. You need to assess them for amputation. You need to assess them for arthritis of joints. So let me give you an example. If you have an examinee who suffered an industrial injury to, let's say, the hip joint, and they've gone through a period of treatment, and they're now ready for the permanent and stationary evaluation. And the permanent and stationary evaluation is some, let's just say 24 to 30 months after the date of injury. Well, it's possible that there could be premature degenerative change of the hip joint as a result of the industrial injury. You need to assess that hip joint for the development of arthritis. Arthritis of the joint is one of the permanent impairments. You need to assess for skin loss. You need to assess for peripheral nerve injury. You need to assess the entire vascular function of the lower extremity. You need to examine for the presence or absence of chronic regional pain syndrome. For the functional assessments, you need to assess range of motion. You need to assess gait derangement. And I've spoken at great length about the necessity of incorporating a formal gait analysis into your routine lower extremity and even spinal evaluation procedures. So you know that if you have a lower extremity case, you need to assess for gait derangement. You need to take them outside and do a formal gait analysis in almost every lower extremity case. Why is that? Because it's required. It's required by the AMA guides. It's one of the functional assessments. You need to be prepared to examine for the presence or absence of diagnosis-based impairments as well, such as fractures, such as ligament injuries of the ankle, of the knee, of the hip, such as meniscectomies of the knee, such as foot deformities, such as hip and pelvic bursitis. So these describe all of the different types of physical examinations that we need to incorporate in our lower extremity examination. And this principle, of course, applies to our other examination procedures for other body parts as well. So think about this. If you have an upper extremity case coming up, you need to have an examination in your template for hip and pelvic bursitis. There needs to be a specific section in your report that demonstrates to the reader that you assess the examinee for the presence or absence of hip and pelvic bursitis. You need to have a separate section in your report that shows the reader of the report that you assess the examinee for losses of muscle strength through the use of manual muscle testing. So these requirements of the AMA guides require special formatting in our QME reports. So let's review that as relates to the lower extremity. Okay, so here's our lower extremity examination template, and we tell the reader that we assess these different types of assessments. We did each one of these in sequence. So first we're going to do all the anatomic assessments, then we're going to do all the functional assessments, then we're going to do all of the diagnosis-based assessments. So we begin here with our examination for all of the anatomic impairments. Okay, all of the anatomic impairments. And let's just review what those were. Limb length discrepancy, muscle atrophy, all of those, okay? So let's go through this now. We begin with some basic palpation, here of the hip, here of the knee, here of the ankle foot, And then we get right into our first evaluation, which is for limb length discrepancy. So here we show to the reader that we have an entire section from here all the way down to here, which includes all of our measurements to assess for limb length discrepancy. So, for example, we do our leg length measurements and we record our findings here in a nice table. We then provide some conclusion here to tell the reader of the report what our conclusions were. We assess both for true leg length discrepancy and also for apparent or functional leg length discrepancy. And then we provide the reader of the report our conclusion. Boom. So that handles the leg length discrepancy impairment. What's the next one? The next one is muscle atrophy. So now we go into our muscle atrophy assessment, and we assess muscle atrophy by taking our measurements both above and below the patella bilaterally. We provide the reader of our report our data in a nice tabular format that they can simply look at and quickly extract the data at a glance. We then provide the reader of the report our conclusion that there either was some atrophy or that there was no atrophy. And included in the template is table 17.6 from the AMA guides, where you can simply refer to the chart here and determine whether or not the examinee qualifies for permanent impairment. So you see how this template is laid out for convenience for both the reader of the report and also for you as the medical evaluator. Now, you as the medical evaluator, we include this chart and table here in the template for you, simply for your reference. When you're done using the table, you would simply delete that from the report so that it doesn't clutter up the report for the reader of the report. But we include that here for your reference so that you don't have to go back and forth to the AMA guides. Okay, what's next? Next is ankylosis, and you can see that we go through an ankylosis assessment of the hip, of the knee, of the ankle. All of the references from the AMA guides are included. We go through an ankylosis assessment of the hindfoot, midfoot, and the forefoot, including all the X-ray measurements such as the os calcis angle. Here's the ankylosis evaluation for the toes. And then we provide the reader of the report with our findings and our conclusions here in text bulleted format that makes it easy for the reader to simply extract the data. And later on, when it comes time to provide our opinions and conclusions, the reader of the report can simply refer back to this section of the physical examination and see that, yes, indeed, that opinion and conclusion is fully supported by physical examination findings. Well, what's the next impairment? Well, what about arthritis of joints, number 5? So we do that assessment here through the use of right hip X-rays. Or if it was a knee case, we would have right knee X-rays, or we would have ankle X-rays, or whatever. And so here's a chart and table that allows you to simply input all of your data, all of your findings. So perhaps you're assessing the right hip, and the examinee had 2 millimeters of cartilage interval at the medial acetabular joint. We know that normal is 4 millimeters, and therefore this examinee could possibly qualify for permanent impairment. Well, what's the permanent impairment of 2 millimeters? We have the chart and table right here, which tells us that 2 millimeter cartilage interval at the hip qualifies for 8% whole person impairment. Okay, so here's the entire arthritis impairment evaluation. And it's already been done for you, and here you provide the reader of the report with your findings and your conclusion, whether it involved the hip, whether it involved the knee, or whether it involved the ankle, foot, or even the toes. Okay? And here are all the different measurements already input for you for the ankle joints, subtalar joints, talonavicular joints, calcaneocuboid joints. It's already done for you and formatted in this template for you. Okay? Now, a specific subset of arthritis of joints would be chondromalacia of the patella. So chondromalacia of the patella is described as a footnote underneath table 1731. And let's just pull that up for reference. Table 1731. 1731. Here we have a reference for chondromalacia. It says that in an individual with a history of direct trauma, with a complaint of patellofemoral pain and crepitation on physical exam, a 2% whole person or 5% lower extremity impairment is given. So it requires crepitation on physical exam. So here's the physical exam section for chondromalacia of the patella. One of the tests that we can use to elicit crepitation would be Clark's test. We also have Waldron's test. We also have patellar apprehension and patellar ballottement test, which, if positive, could indicate the presence of permanent impairment due to chondromalacia of the patella. Okay, what's next on our assessments? Next, we assess for peripheral nerve injury. Here's your peripheral nerve examination with all the reference charts and tables from the AMA guides. Begins with sciatic nerve tension signs. Continues with reflex examination of the peripheral nerves, which would be the femoral nerve and the tibial nerve. Then goes into the entirety of the motor exam. The motor exam for the obturator nerve, the femoral nerve, the sciatic nerve, for the common peroneal nerve. And these are all nerves that are described here in the AMA guides. Here's femoral, here's obturator, here's sciatic. And all the specific muscle tests are already laid out for the reader of the report. So the reader of the report knows that when you did resisted hip adduction for testing the obturator nerve, you tested the pectineus, the adductor brevis, the adductor longus, the adductor magnus, and the gracilis. These are the muscles that are described right here as being innervated by the obturator nerve. You tell the reader of your report that those muscles were strong, they were symmetric bilaterally, and that, in your opinion, this nerve is functioning normally. Can you see how persuasive and how powerful this type of formatting is? Because it conveys to the reader of the report that you've done the test exactly as described by the AMA guides. What about the femoral nerve? Femoral nerve innervates the quadriceps here, such as the vastus lateralis and the vastus intermedius, such as the rectus femoris, such as, where's the vastus medialis? Should be listed here as well. So you tested resisted knee extension, okay? And it's formatted exactly as described by the AMA guides. Check out this sensory examination. When the reader of your report reads this, they say, oh my God, the guy tested the lateral femoral cutaneous nerve. He tested the genitofemoral nerve. He tested the femoral nerve. Where does he know to test all of those nerves? Well, it's given to us right here in the AMA guides. It's given to us, and we're told exactly which nerves to test. There's the lateral femoral cutaneous, there's the genitofemoral, there's the femoral obturator, all of those nerves. Well, guess what? Those are going to be the ones that we test. And in this way, we show the reader of our report that our procedures exactly follow the requirements of the AMA guides, which is different from the way we do it in our clinical practice. Here's all the nerve examinations of the foot, which are described right here in Table 17.8. So this is a powerful report formatting to demonstrate the reader your attention to detail and your accuracy in performing your procedures consistent with the procedures the way they're described in the AMA guides. We continue on with the vascular exam. We continue on with our evaluation of crypts. And you need to have a specific section in your report where you demonstrate to the reader that you considered that possibly they could be left with an impairment due to chronic regional pain syndrome. However, you checked them. You checked the skin and found that it was neither taut nor shiny. You found that there was no edema or swelling or redness. You found that there was normal hydration with no signs of sweating. There was no other autonomic findings. And to palpation, when you touched the lower leg, you had a normal sensory response. In other words, there was no finding for allodynia. And therefore, in your opinion, there was no permanent impairment due to chronic regional pain syndrome. So that concludes the anatomic impairments. We then go on to the functional impairments. We begin with a few functional maneuvers to establish a baseline of physical function. And then we get right into AMA guides procedures such as range of motion, all of which is contained in tabular format for the hip, for the knee, for the ankle, for the foot. We have all of the AMA guides normal findings here for the reader to quickly reference. And then for the doctor's reference, we have the charts and tables that provide for the motion impairments of the hip, knee, and ankle. We then move on to the gait evaluation, where you describe your findings on gait observation. And I've talked at great length in the past on the necessity of the formal gait evaluation, and it's here in this section of the report that you would report your findings of the gait evaluation. Okay, which is one of the functional assessments. Here's a couple charts and tables from the AMA guides to quickly reference. We then go on to our manual muscle testing, and all of your findings are presented to the reader in tabular format. And many doctors do not use table formats. They simply use paragraph text, which is cluttered and is not clear. And notice how the findings are so clearly presented when you use a table format. You can simply input the examinee's findings. Below the chart and table, we have a description of what the various gradings represent, such as a +5 represents complete active range of motion against gravity with full resistance, some resistance, and without resistance. And here you provide the reader of your report with your summary and conclusion. And then here is the chart and table that provides for the permanent impairments based upon your findings, whether that be grade 4, grade 3, grade 2. And once you're done with the chart and table, you would simply remove it from your report so as not to clutter up your report. But we include it here for you for your reference. And then finally, once we're done with our functional assessment, we then move on with our assessment for the presence of diagnosis-based conditions. And here's the chart, table 1733, that describes all of the different diagnoses and conditions that the AMA guides provide for permanent impairment 4. So this is given to you here for your reference. So the first of which is fractures. So it's rare that we're going to have examinees who suffer fractures, but if they do, we would discuss that here. We then go into the assessment for ligament injuries, both of the knee, and here's the entire section on knee ligament stability tests. We test the collateral ligaments, we test the cruciate ligaments, and we use several different examination maneuvers such as anterior draw, Lockman's, and pivot shift. For the posterior cruciate, we have a couple of different tests. For ankle ligament stability tests, we also order stress x-rays, and we would provide our findings here. Our findings of those stress x-rays, we would provide those findings right here in this section. We also have several physical examination maneuvers for the assessment of ankle ligament instability, such as the ankle draw, such as varus stress and talar tilt tests, and then also valgus stress tests. Isn't this amazing, this physical exam formatting? So you demonstrate here to the reader that you've considered the possibility of each of the permanent impairments that are described on page 525 of chapter 17. And you simply go through the physical examination, and you do an ankle draw test and you find that it's negative. You do a varus stress test and you find that it's negative, and you conclude that there's no permanent impairment due to ligamentous instability of the ankle. Finally, we assess for meniscus injuries and or meniscectomies. We have a group of tests here. And then finally, we assess for both foot deformity and the presence of hip and or pelvic bursitis. Some examinees may qualify for permanent impairment due to lower extremity joint replacements. With the AMA guides, this refers primarily to hip joint replacement and knee replacement. There's no description in the AMA guides. Here's hip replacement here, and knee replacement is on another chart and table. Well, here's knee replacement here. There's no description in the AMA guides of ankle joint replacement or ankle arthroplasty. So you have to do your permanent impairment rating for ankle replacement using any combination of these other methods. Okay, and then here in this section, we would simply provide a summary of the lower extremity examination findings. Okay, doctors, so isn't that a powerful method of reporting your physical examination findings in a way that's exactly consistent with the requirements of the AMA guides? And you would fashion the remainder of your physical examination section, regardless of the body parts involved, exactly the same way. In other words, your cervical spine exam should be consistent with the AMA guides. Your lumbar spine exam should be consistent with the AMA guides. We have no need for Kemp's tests and Milgram's tests and all those other tests that we talked about with our lumbar spine exam, because none of those are described in the AMA guides. So the principle is to format your physical exam properly in accordance with the procedures exactly as they're described in the AMA guides. That way, if you're ever in deposition, or if your opinions and conclusions are ever challenged, you can refer back to your physical examination, and you can simply say, my opinion and conclusion is supported by ABC physical exam findings. I perform my physical exam exactly as it's described in the AMA guides, and on that basis, I find no reason to change or modify my opinion or conclusion. Now, one more point before we conclude this program, and that is, not only do we need to format our report exactly in accordance with the AMA guides, but we need to perform our physical examination maneuvers also exactly as the AMA guides describe them. We need to use the exact instrument. We need to use the exact measuring device. We need to perform our physical examination maneuvers exactly as are described in the figures of the AMA guides. And this became important to me one time. I had some of my physical examination findings for upper extremity challenged by a second opinion evaluator. And the second opinion evaluator discredited many of my opinions and conclusions. And one of his discredits involved him invalidating my range of motion findings. And I think this was the range of motion findings of the shoulder. Yeah, it was of the shoulder. And he said, Dr. Carpenter's range of motion findings for the shoulder are not valid because the AMA guides require that range of motion measurements be obtained with inclinometer versus long arm protractor. And so I went to the appropriate section in chapter 16, and let's just do that. Let's just do that for demonstration purposes. I went to that section where it shows the range of motion due to, let's see, evaluating abnormal motion. And so I went to that section of the AMA guides for the shoulder, and it clearly depicts a long arm goniometer here in figure 1644. So when I prepared my rebuttal report, I simply referred to figure 1644 and insisted that my physical examination maneuvers were done exactly as required by the AMA guides, and my opinion was therefore upheld. So let me ask you, doctors, what did you think of that formatting of the lower extremity physical exam? I'm sure you'll agree with me that that report format and that report flow and that report process is very impressive and it's very powerful. And that leaves us with a couple of conclusions to summarize today's program. And these are the principles that I want to give you as the take-home messages for today's program. Number one is I want to encourage you to ramp up your physical examination. You know, I've said this before, and that is that the physical examination is the exclusive domain of us as doctors. You know, many parties are going to be reading our reports, and many parties can comment on our reports, and many parties can dispute certain sections of our reports. Well, no party should ever be able to dispute your physical examination findings. The physical exam is the exclusive domain of us as doctors. So therefore, in my opinion anyway, and this is the take-home message that I want to share with you, it's my opinion that the physical examination that we perform should be reflective of our skill, of our talent, and of our attention to detail. The physical examination section of our report should be an absolute masterpiece. It should be a section in your report of which you're most proud. When a reader looks at your physical examination section of your report, what should they conclude? Well, I would hope that they would conclude that, oh my gosh, this guy or this gal is a fantastic doctor, is a thorough doctor, is a knowledgeable doctor, is a meticulous examiner. Isn't that what you want the reader of your report to conclude? Isn't that what you want your examinee to conclude? That, my gosh, they just had the very best examination that they've ever had, and that you're the very best examiner that they've ever had. That's the conclusion that we're after. Now, as far as the readers of our report, including the claims administrators, applicant attorneys, defense attorneys, DEU raters, perhaps workers' compensation judges, There's a couple of conclusions that we want those parties to arrive at, and that is we want them to see that we've done our physical examination procedures exactly as described by the AMA guides. And this is going to require a subtle shift, a subtle mental shift, and a subtle procedural shift for many doctors, because we get so accustomed to doing things a certain way in our clinical practice. We become very standardized and very systematized, and sometimes those systems don't neatly fit into the type of work that we do as qualified medical evaluators. So this is going to require that you go through some subtle and profound shifts in your procedures, but you want the reader of your report to clearly conclude that you followed the letter of the AMA guides exactly. And then you want to present your findings to the reader in an organized, clear fashion, also in a format that exactly follows the format described in the AMA guides. And we used here in today's program, we used the lower extremity to illustrate this general principle. But of course, this would apply to any body part involved in the evaluation. So scrap your physical examination procedures that you do in your clinical practice and adopt specific procedures from the AMA guides for your qualified medical evaluation practice, and report your findings in a clear format exactly as described by the AMA guides. This will infinitely increase the credibility, the persuasive power, and the irrefutability of your opinions and conclusions. So doctors, I hope this helps you. Next week I have another fabulous presentation for you regarding putting the final stamp of credibility on your report, and that is going to involve a discussion of what we refer to as substantial medical evidence. And I have a surprise for you at the end of next week's presentation. I'm not going to tell you what it is, but I'll just tell you now that I have a surprise topic that will certainly blow your mind and will forever change your QME reports forever, for the better. I can tell you that with certainty right now. So for now, this is Dr. Perry Carpenter. It's been my pleasure to be with you here today. I look forward to being with you next week for part 4 of our program on QME report writing mastery. And for now, I'm wishing you best of success in your career as a qualified medical evaluator.